Bismillahirrahmanirrahim. Today we are going to study infarction and shock. Let's define infarction. Whenever the blood supply of an affected tissue is occluded or blocked, you will see ischemic necrosis in that site. This is known as infarction. Now, the clinical illness which you might see with infarction are, let's see a few examples, like myocardial infarction, cerebral infarction. These are those infarctions in which you will see death. Then there is pulmonary infarction, in which the lung parenchyma is affected when its blood supply is occluded. Now it depends on the severity. If it's not such a severe condition, the patient can survive. But in severe conditions, even pulmonary infarction can lead to death. Then bowel infarction, again, this is a very serious condition, and this too, if not intervened, can lead to death. Another classical example is the infarction which is seen in distal extremities. A very good example would be your gangrenes seen in diabetes mellitus. Now, the causes of infarction. The most common cause of infarction is arterial thrombosis or arterial embolism. Lesser common causes include vasospasm, when the blood vessel spasms, expansion of atheroma secondary to intraplaque hemorrhage. Now, whenever there is plaque deposition in the blood vessels, those areas become points of weakness and they can rupture. When they rupture, the hemorrhage, it spreads within the blood vessels, causing an atheroma. And as the hemorrhage expands, it increases, so does the atheroma. And this leads to a compromised blood supply, which can cause infarction. Then extrinsic pressure on the vessel wall, due to which the vessel becomes occluded, like a tumor or an edema which is present outside the blood vessel, but it compresses it, and this compression stops the blood flow within the vessel. Now, the uncommon causes: vessels can twist around each other. There can be a traumatic rupture of the blood vessels, or the blood vessels can get trapped in hernial sacs. Then another cause which can lead to infarction are venous thrombosis. Now, venous thrombosis, especially where you get a single vein which is draining a certain tissue. If that gets blocked, there is blood stasis. When there is blood stasis, thrombus forms, and this thrombus can then occlude the flow of blood out of that tissue. Now, the outcome of this is going to be congestion, and if it's an acute case, then the infarction can occur pretty rapidly. But if it is a gradual process, then there is time for the arteries to form collaterals which bypass the occlusion, and they can perfuse the affected tissue. Now let's look at the different types of infarction. Now, infarction is classified in two ways. One is on the basis of its color, like red infarcts and white infarcts. Red infarcts are also called hemorrhagic infarcts, and white infarcts are also known as anemic infarcts. The other classification is on the presence or absence of microbial infection present within the infarct. So if an infarct has some microbial infection present in it, it is known as a septic infarct, and if it is a sterile infarction, then it is known as bland infarct. Now let's look at the red infarct. The red infarct occurs whenever there is venous occlusion. The second point is you will see red infarcts where there are loose tissues. A classical example is lung. Loose tissue organs are very susceptible and they can easily accommodate a collection of blood within their tissues. So whenever there is some loose or spongy tissue, there are more chances of collection of blood in the infarcted zone. Red infarcts are also seen in those tissues which have got a dual blood supply, because if one blood supply is occluded and it causes infarction, the other blood supply, when it takes over, it gives it the red color. In tissues which were previously congested and had a sluggish blood flow, those tissues will also exhibit red infarcts. And in a tissue where the blood flow had been completely obstructed or occluded, and after some time the blood flow is re-established, again you will see a red infarct. So these are the main salient points of red infarct. Here in the picture you can see the red area. These are the red areas which show red infarction. Now we come to the white infarcts. White infarcts occur when there is arterial occlusion to a tissue. And this is usually seen in solid tissues like heart, spleen, and kidneys. Now, a solid tissue limits the amount of hemorrhage to percolate or seep into it. So the area of ischemic necrosis or the area of infarction, that remains pale or white in color. This here in the picture you can see this triangular area. This is a white infarct. This is a solid tissue and it did not allow, due to its compact nature, for the hemorrhage to easily spread like it did in the red infarct where the tissue was spongy in character. So due to this property, the infarcts remain white or pale in color. Now let's look at the morphology of the infarcts. An infarct is always going to be wedge-shaped. Wedge-shaped means like a triangle. And if you look at this wedge shape or this triangle, the apex of the triangle is the point where a vessel is occluded. And the base of the triangle is going to form the periphery of the infarct. So if we go back to this picture, you will see this is the apex of the wedge. So the occlusion is going to be at this level, and this is the base of the infarct. So between the occlusion and the base, you see a triangle, and this is where the infarcted area exists. Now, the infarctions, the arterial occlusions, which occur in tissues which do not have a dual blood supply, you will see that the infarct, as the time progresses, becomes paler and paler with time. And it is seen that white infarcts are predominantly seen in solid organs and tissues. Now the red infarcts, like we see in the lungs, what you're going to see is, as there is a dual blood supply and the tissue is spongy and it can accommodate all that blood which is accumulating there, what you are going to see is, in response to that collection, that macrophages are going to come and all the RBCs which have managed to escape out of the blood vessels, they are phagocytosed by these macrophages. Within these macrophages, then these RBCs are degraded, and ultimately they reach their end product, which is hemosiderin. So you will see that brown pigment which present within these macrophages. Now, there are uh, and another thing that you're going to see is, in majority of the cases, the tissue which is surrounding these infarcts, you might see inflammation in these tissues. Now, as the inflammation subsides and a person goes towards recovery, these infarcted areas will be replaced by fibrous scar tissue. Except for the brain, because in the brain, there is liquefactive necrosis, and after phagocytosis, what you see in brain is cavitation. Now let's look at the morphology of these infarcts. As basically the ischemic necrosis that you will see in these cases, majority of the necrosis is going to be of the coagulative type, and the recovery is going to depend how much of the underlying stroma, the connective tissue network that was spared. We have already studied in healing and repair that if the underlying stroma is spared, the repairing or the regeneration of the tissues is much better. So it depends how much the collagen fiber matrix was destroyed. So the repairing will be directly proportional to the severity of the damage that has been done to the connective tissue. The more is spared, the better the repairing. The more severe the damage, the repairing and the scar formation will be in a much higher intensity. Now, the septic infarcts, these are seen when infected vegetations which are present on the valves of the heart, they break away and embolize, and then they are stuck in some blood vessel, causing its occlusion. This results not only in infarction but septic infarction, because stoppage of the blood supply causes infarction, and as the stoppage is caused by an infective material, you will also find superadded infection in that area. Another mode through which infection you will see septic infarcts are when microbes they infect necrotic tissue, and when this necrotic tissue is washed away in the blood, these microbes which are present in this necrotic tissue, they go in the circulation, and when they occlude a blood vessel, they not only cause infarction, they also cause infection in that area. Now, the factors which influence infarction development. First of all, the anatomy of the vascular supply. Organs having a dual blood supply will exhibit red infarcts. Now, the common organs which you will see which exhibit dual blood supply are lung. It has the pulmonary system and the bronchial system. Liver, it has the hepatic system and the portal system. Hand and forearm, it has again the radial arteries and the ulnar arteries. These are a few examples which have a dual blood supply. Now the thing is, whenever an obstruction occurs in one arterial system, the other arterial system takes over. And if it's not an acute episode, if it's a gradual process, then there is ample time for collaterals to develop and to start perfusing the affected areas. Now, where the blood supply is not of the dual system, there is a single blood supply, like in the kidneys and in the spleen. When these are obstructed, then there is no other choice. There is going to be infarction. There are no alternate blood vessels which can take over and save that tissue. Another factor is the rate of occlusion. In slowly developing obstructions, as I told you earlier, there is enough time for collaterals to develop, and these collaterals can re-establish the blood flow in that affected area. The better the collaterals, the lesser the infarction and damage to the tissue. Then comes tissue vulnerability to ischemia. Now, the different tissues in our body, they have different sensitivity where ischemia is concerned. Like the neurons, they are the most sensitive. They can just live up to 3 to 4 minutes if their blood supply is blocked. The myocardial cells, they can survive up to 20 to 30 minutes. After that, infarction sets in. The fibroblasts, which are present within the myocardium, they can be viable even for many hours. So it depends on the tissue to which a blood supply has been occluded. Another factor which affects infarction is hypoxia. If there is abnormally low content of oxygen, no matter what the cause, there is an increased chance of infarction. And lastly, the factor which contributes to infarction is the severity and duration of ischemia. The more severe the ischemia, the longer the period of ischemia continues, the greater the chance of infarction. The earlier you are able to control the ischemia, the milder there is occlusion of the blood vessels, the lesser the chance of infarction. So this is a general overview of infarction, and if there are any questions regarding it, you can put them in the chat box after the lecture, and then we'll get back to I'll get back with you with the answers. Now we proceed to shock. Shock is defined as a failure in the circulatory system to maintain adequate cellular perfusion, and this results in a widespread reduction of oxygen delivery and other nutrients to the body. In short, what we say, the circulatory system collapses, and its collapse results in hyperperfusion of the body tissues. In this, the mean arterial pressure falls below 60 mm, or you can say the systolic blood pressure falls below 90 mm per mercury. Now, whatever the etiology might be, if systemic hypotension results, this is due either to a decrease in the cardiac output or a decrease in the effective circulating blood volume. So either the blood volume, the effective circulating blood volume is decreased, or the cardiac output is decreased. And when this occurs, there is hyperperfusion. Hyperperfusion leads to ischemia, and ischemia can ultimately lead to infarction and cell death. Now, adequate perfusion in our body depends upon arterial blood pressure, and our blood pressure in turn depends upon cardiac output and peripheral resistance. If our cardiac output is good, if our peripheral resistance is within normal range, we maintain a very good arterial blood pressure, which is optimum for a healthy tissue perfusion. Now, our cardiac output is basically a product of stroke volume multiplied by heart rate. Stroke volume is the amount of blood which is pumped by a heart in one heartbeat. Now, stroke volume depends upon three factors. Preload. Preload is your total blood volume. Afterload, this is your arterial resistance, and your myocardial contractility. That is the beating strength, the contracting strength of your heart. Now, shock occurs if the preload is decreased, that means the blood volume is decreased, or your afterload is decreased, your peripheral resistance is decreased, or if your myocardial contractility is decreased or it fails. So your heart is not pumping at its full strength. These are the three factors which can lead to a decrease in cardiac output, which can in turn lead to shock. Now let's see the different types of shock. First, we look at hypovolemic shock. Hypovolemic shock occurs when the blood volume is decreased. A reduction in blood volume can lead to shock, but not every blood volume leads to not reduction in every blood volume leads to shock. When at least 25% or greater of your blood is lost, then a person goes into shock. 10 to 15% blood loss, a person can definitely sustain this much blood loss, and the body can definitely adapt to this loss. Usually you will not see any significant sign or symptoms associated with such a blood loss. But if the blood loss is more than 25%, then a person will go into hypovolemic shock. When a person goes into hypovolemic shock, what happens is there is a reduction in the blood volume. That means the preload decreases. When the preload decreases, there is less amount of blood coming into the left ventricle. So, when there is less blood in the left ventricle and the heart contracts, the cardiac output decreases. When the cardiac output decreases, there is hyperperfusion of the tissues. Hyperperfusion leads to ischemia and infarction and shock. So the causes of hypovolemia, where blood volume can be lost, foremost and most important, hemorrhage, then diarrhea, burns, trauma, etc. These are all conditions where your body fluid, your effective body fluid which is circulating in your blood vessels, it is lost from your body. Now let's look at cardiogenic shock. This is another type of shock. In this, the effective circulating volume of your blood is impaired. In this, the blood volume is not lost, but the circulating blood volume becomes impaired. So your cardiac function, your cardiac performance becomes dysfunctional. It becomes below par. Your heart is not able to pump out enough blood to perfuse your body tissues. So if you look at this condition hemodynamically, the diastolic blood pressure is going to be less than 60 mm per mercury. Left ventricular filling pressure is going to be greater than 18 mm per mercury. Now this means that the pressure in your left ventricle has increased above normal. When your left ventricle goes into diastole, that is when it relaxes, the blood fills up the left ventricle. Now, if the pressure is increased in your left ventricle, it will not be able to relax. When it is not able to relax, it will not fill up properly. The filling is going to be incomplete. So when the heart contracts, your cardiac output is going to be reduced. The third thing is cardiac index is going to be less than 1.8 liters per minute per meter square. This is the ratio between the volume of blood pumped by your heart in 1 minute divided by the body surface area of your body. And all these conditions are usually coexisting with pulmonary edema. Now, the causes of cardiogenic shock can be myopathic or mechanical. Myopathic causes, these are related to the heart itself, like acute myocardial infarction, myocarditis, dilated cardiomyopathies or hypertrophic cardiomyopathies. These you will study in the next semester. And myocardial depression in septic shock. All these conditions are directly related to the heart, where the heart is compromised and it fails as a pump. The other causes come under the mechanical causes. Now they can be intracardiac or extracardiac. Intracardiac are left ventricular outflow obstruction. For example, like aortic stenosis, there is narrowing of the aortic valve, due to which the heart has to work more to pump that blood through that narrow opening. Then reduction in forward cardiac output. This is seen in aortic regurgitation. Then arrhythmias, when the different parts of the heart, they are beating at their own rate. The heart is not beating as a single organ. Again, the cardiac output, the contractility becomes ineffective. Then the extracardiac causes, there comes the pericardial tamponade. Pericardial tamponade is when any sort of fluid accumulates in the pericardial cavity. And when fluid accumulates in the pericardial cavity, what happens is the heart is not able to relax. When it doesn't relax, it is not able to fill up properly with blood. When the ventricle is not able to fill up with blood in diastole, and when systole comes, your cardiac output decreases. Tension pneumothorax, in this air or gas accumulates in your pleural cavity and it presses the heart and it does not let the heart expand in diastole in a proper manner. Then acute massive pulmonary embolism, again, this is something which leads to decreased cardiac output, because when there is obstruction in your pulmonary tree, your blood flow becomes impaired and the normal amount of blood cannot reach your left heart. Then severe pulmonary hypertension, again, this is something where normal blood flow becomes hampered and normal flow cannot reach the left ventricle, which can output, which can, what should I say? The left ventricle is unable to give normal output, which might be sufficient to perfuse your body tissues. Now we come to another type. This is known as distributive shock. This is a group of shock types, and in the shocks which are included in this group, the common pathology lies in vasodilatation. There is peripheral vasodilatation seen in this in these subgroups. Due to this vasodilatation, there is decrease in blood pressure, and this leads to hyperperfusion. And the interesting thing is that despite this vasodilatation, in these cases, the cardiac output is either normal or even high. Now, the causes in this are septic shock. We'll just get to septic shock in the next topic. Neurogenic shock, this is seen in anesthetic procedures, in spinal cord injuries where nerve is damaged. Anaphylactic shock, this is initiated by immunoglobulin E. This is hypersensitivity type 1 reaction, and it is usually related with allergic conditions. In this, there is systemic vasodilatation with increased vascular permeability. Again, this is another topic which we will study later in great detail. Then there is endocrine shock. In this, there is adrenal insufficiency. In all these four varieties of shocks, the basic pathology is there is peripheral vasodilatation, due to which there is decrease in blood pressure. Decrease in blood pressure leads to hyperperfusion and shock. Before we proceed further, there are 2 or 3 definitions that I want to make you familiar with. There is a thing known as bacteremia. Bacteremia means there is presence of viable bacteria in your blood. Now, the thing is, viable bacteria means that this bacteria, if given the opportunity, may become pathogenic and damage your tissues. So, the viable bacteria, it may or it may not cause disease in the host. And if viable bacteria is present in a person and he donates blood, that viable bacteria again may cause disease to the person to whom the blood has been donated. So viable bacteria just means that this bacteria is there and it is looking for an opportunity. If you provide an opportunity to this bacteria can become pathogenic. Septicemia. Septicemia is systemic infection which is present due to the microbes and the toxins that they have released in the blood. And sepsis, this is the systemic response that our body gives to severe infection. And this response is given by macrophages which release certain cytokines, and these cytokines in turn they act on certain end organ receptors to elicit a definite response. Now let's look at septic shock. Septic shock is caused by systemic infection, most commonly by gram-negative bacteria. Septic shock can also be caused by gram-positive and fungal microorganisms, but most commonly the causative agent is usually a gram-negative microorganism. Now, to define septic shock, it will have hypotension, that is low blood pressure. You will see organ dysfunction, and you will see that the patient will not respond to any fluid administration we give as treatment. Now, what is the pathogenesis of septic shock? Usually the infection site is a local one, but when this local infection spreads into our blood, it is carried through our blood to all the parts of our body. Usually the causative agents are gram-negative in nature, and they produce endotoxins. Endotoxins are a part of the cell wall of gram-negative microorganisms. These endotoxins are lipopolysaccharide in nature, And when the cell wall of these gram microorganisms are degraded, these endotoxins are released into our bloodstream. Now these lipopolysaccharides, they bind with CD14 molecules which are present on leukocytes, especially the monocytes and macrophages, or they can be present on endothelial cells, and there are a variety of other cells on which CD14 can be present. So these lipopolysaccharides bind with the CD14 and they start a cascade of cytokine mediated events. Now what happens after this is these events, this binding of the lipopolysaccharides, this binding, mononuclear phagocytes respond, and they respond by producing TNF, tissue necrosis factor, which in turn induces the production of interleukin-1. This TNF and interleukin-1, they act on the endothelial cells and further cytokines are released. The cytokines which are released are interleukin-6, interleukin-8, and secondary effectors like nitric oxide and platelet aggregating factor. Now, the nitric oxide, this has a systemic effect, and this effect is of vasodilatation. Nitric oxide causes systemic vasodilatation, due to which there is decrease in the blood pressure, and this leads to shock. Now, let's look at the different organs and what happens to them when there is septic shock. Heart, the myocardial contractility decreases, resulting in decreased cardiac output. The blood vessels, they show systemic vasodilatation, due to which the peripheral resistance is decreased. When the peripheral resistance is decreased, they are more liable for endothelial injury. This endothelial injury activates the coagulation system, and this leads to DIC. DIC is disseminated intravascular coagulation. This is a condition in which small thrombi and small bleeding points are simultaneously formed throughout our body. Then comes the lungs. Septic shock causes ARDS, that is Adult Respiratory Distress Syndrome. This is a syndrome in which the alveolar capillaries are damaged and your alveolar sacs are filled up with fluid. So there is no space for the gaseous exchange to take place. So hypoxia results as no oxygen can be exchanged as the alveolar sacs are filled up with fluid. Now let's look at the stages of shock. The first stage, the initial non-progressive stage, also known as early compensatory period. In this stage, our body's compensatory mechanisms are activated, and if we intervene at this stage, we can reverse the shock. Now, the mechanisms that are involved are neurohumoral. What we see is there is reduction in the cardiac output when there is shock. This reduced cardiac output stimulates our peripheral and central baroreceptors. These in turn stimulate our sympathoadrenal stimulation. This stimulation releases catecholamines in the range of 200-fold. That is, they are released 200 times more as compared to the normal levels. Catecholamines have they have effect on the heart rate. They increase the heart rate. they increase the cardiac output, and they raise the blood pressure by causing vasoconstriction. This stage, where there is increased heart rate, increased blood pressure, and increased cardiac output, this phase is known as major compensatory response. In addition to this, when there is reduction in cardiac output, in short, there is hypoxia. When there is hypoxia, your kidneys respond to hypoxia by stimulating the renin-angiotensin system. This system, what it does is it activates the antidiuretic hormone, and your body starts conserving water and sodium, and it starts adding more volume to your circulation. So this is the stage that if we intervene, the state of shock can be very easily reversed without any fatal or severe damages. If we do not intervene here and this stage goes untreated, we proceed to the second stage, which is known as progressive stage or established shock. Now, if we reach this stage, the tissue hypoxia, tissue hyperperfusion has been established. The effective circulatory blood volume, it has been more compensated. The circulation has worsened, and there has been a metabolic imbalance has started, because as hypoxia starts and as it worsens, your aerobic respiration converts to anaerobic respiration. Now, this anaerobic respiration causes glycolysis, and this reaction causes a lot of excessive production of lactic acid. When lactic acid is produced, the tissue atmosphere becomes acidic and the pH decreases. Here, your hypoxic cells also start leaking glucose, and there is increased glucogenolysis. Now, this leads to impaired carbohydrate metabolism. When the carbohydrate metabolism becomes dysfunctional or impaired, your ATP production decreases. When your ATP production decreases, your energy is decreased. When energy is decreased, your sodium potassium ATPase pumps, they fail, and sodium and water starts entering into these cells, and these cells swell up. This is known as sick cell syndrome. And apart from this, anoxic injury, as we discussed earlier, disseminated intravascular coagulation also starts. If we don't intervene in the second stage, then comes the last and the fatal stage, which is known as the irreversible stage. In this, the cellular and tissue injury becomes very, very severe. The hypoxia is very severe, and at this stage, if you intervene and try to give any sort of treatment, the patient becomes unresponsive. The patient will not respond to any treatment at this stage. Death becomes inevitable. What happens is, by this time, there is widespread destruction of the tissues and organs. The lysosomal enzymes have leaked out, and they are further aggravating the shock stage. The myocardial contractility, it has worsened because of increase in nitrous oxide. Your bowel, it shows ischemia, and it shows tissue destruction, due to which the intestinal flora it has entered into the circulation and bacteremia has resulted. Now, this bacteremia has ample opportunity to turn pathogenic because already the body has become dysfunctional and it is suffering. So, this further adds to the shock. The ischemic injury to the kidneys results in acute renal failure, and at this stage, whatever you might try to do, death is inevitable. You cannot save the patient. So, in cases of shock, the clinical course that you might see is hypovolemic shock or cardiogenic shock. In these two shocks, what you are going to see is hypotension, wheel, uh, wheel formation, rapid pulse, tachypnea, cool clammy skin, cyanotic skin. And in these two conditions, yes, if you intervene, you can definitely save the patient. In septic shock, initially the skin is going to be warm and flushed due to the vasodilatation, but as the shock proceeds, patient will get confused, restless. There is going to be decreased urinary output as your kidneys fail, and ultimately there is going to be coma and death. So septic shock is definitely more severe and fatal as compared to the other two shocks. But still, whatever the shock might be, you have to intervene it the earliest possible, because any type of shock, if you let it go to its end stages, it can be fatal. Thank you very much. And if there are any queries, please leave them in the chat box and I'll get back to you with the answers. Thank you so much. Allah Hafiz.